Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AbbVie.
Hi, I'm Jeffrey Curtis, the Marguerite Jones Harbert Jean Ball Endowed Professor of Medicine in the Division of Clinical Immunology and Rheumatology at the University of Alabama at Birmingham. Welcome to this program titled JAK Inhibitors in Rheumatoid Arthritis, Overcoming Challenges and Maximizing Impact. Joining me today are Dr. John Giles, Associate Professor of Medicine in the Division of Rheumatology and Cow Autoimmunity Institute at Cedars-Sinai Medical Center in Los Angeles, California, and Amanda Mixon, Physician Assistant at UC Health Rheumatology Clinic, Harmony Campus in Fort Collins, Colorado. Welcome, John and Amanda. Our topic for today is targeted therapies for RA, including biologic DMARDs, and in particular, targeted synthetic DMARDs, or TS-DMARDs, including JAK inhibitors. These therapies have significantly improved the range of options available to us as we treat patients with rheumatoid arthritis. In addition to reducing signs and symptoms in RA, these treatments, as we well know, can stop disease progression and improve physical function and quality of life. TS-DMARDs, like JAK inhibitors, inhibit intracellular signaling of multiple cytokines, and they do that through affecting the signaling pathways of JAK1 to 3, as well as TYK2. JAK inhibitors interrupt the JAK-STAT pathway, which is a critical intracellular signaling process that promotes inflammation and mediates immune responses. Pro-inflammatory cytokines signaling inside the cell are inhibited by JAK inhibitors, and this blocks transcription of genes that drive inflammation. As I think all of us know that treat patients, there's 3 approved JAK inhibitors in rheumatoid arthritis: tofacitinib, baricitinib, and upadacitinib, that are indicated in adults with an inadequate response or intolerance to 1 or more TNF inhibitors. All 3 of these have undergone robust phase 3 development programs and have shown to be effective in people with an inadequate response to methotrexate or biologic DMARDs. They're considered to have at least comparable and perhaps even numerically superior efficacy to biologic DMARDs, and have also been shown to improve patient-reported outcomes, including pain, fatigue, and quality of life. That said, we don't have head-to-head trials that are adequately powered comparing JAK inhibitors to one another. The focus of the program today is to speak to some of the safety coming out of randomized controlled trials and their long-term extension studies. And there's a variety of things to talk about, including serious infection events, opportunistic infections, malignancy, and major adverse cardiac events. And some of the infections that we'll speak to, of course, include herpes zoster. A couple years ago, data were published on safety findings from the oral surveillance trial, raising concerns about the safety of JAK inhibitors that resulted in the addition of a black box warning. John, very briefly, can you tell us about this trial and its top-level results?
Sure. Oral surveillance was a very large trial that was FDA mandated. It was a phase 3/4 trial with over 4,000 patients. They were randomized to receive 2 doses of tofacitinib. One arm was 5 milligrams BID, the other was 10 milligrams BID. This was compared to a TNF inhibitor arm, which was either adalimumab or etanercept. The primary endpoints of the trial were either major adverse cardiovascular events, so these are myocardial infarction, stroke, or sudden cardiac death. And the other primary endpoint was malignancy. This was an events-driven trial and it enrolled patients with rheumatoid arthritis who were greater than 50 years of age. They had moderate to severe rheumatoid arthritis and they were failing methotrexate, and they had at least 1 cardiac risk factor, including people who had known cardiovascular disease events in the past. This was a non-inferiority trial compared with TNF inhibitors, and the non-inferiority margin was 1.8. The patients were a fairly expected rheumatoid arthritis clinical trial group, mostly women. The median age was 60. They had disease for about 10 years, and they were enriched for cardiovascular risk factors. So they were heavier, the high percentage of current and ex-smokers, and a lot of cardiovascular risk factors, as you can see here. And the findings were that there was numerically higher rates of major adverse cardiovascular events, as can be seen here, as well as malignancy. The tofacitinib was not non-inferior to the TNF inhibitor arm because the upper bound of the 95% confidence interval went above 1.8 for both of these outcomes. But when you look at the number needed to harm, it was actually quite high. Especially for the approved dose of tofacitinib, 5 milligrams twice daily per year. It was 567 for major adverse cardiovascular events and 276 for cancers, mostly lung cancer in these patients. When you look aggregated over a 5-year period, it was lower, but it was still a very high number needed to harm.
Thanks, John, for that great summary. Amanda, can you speak to what we know about both the incidence and some of the risk factors for herpes zoster and serious infections, as well as venous thromboembolism events?
Yeah, I mean, I think at this point, most of us are well aware that patients on JAK inhibitors are at a higher risk for herpes zoster. And so I think it's a good opportunity to remind everyone that it's important. When I diagnose rheumatoid arthritis, one of the first things that I do is I ask people to get up to date with their vaccinations, including shingles, because if at some point we do want to put them on a JAK inhibitor, right, like we want to know that they're well protected. But that's really what it showed, is that patients that were on JAKs were and specifically to oral surveillance, were at a higher risk for herpes zoster when compared to people that were on the TNF arm. Really, when we look at serious infections, this could be cellulitis, pneumonia, UTIs, opportunistic infections. These patients also were at a higher risk. It did seem to be dose dependent. So patients that were on the higher dose of tofacitinib were at a higher risk, which was also seen in the VTE events as well. So I think that's just really important to note that at higher doses, which we don't really use, at least in our rheumatoid arthritis patients, there were higher rates of infection when you compare that to the patients that were on 5 milligrams twice a day, which is what we use, in our world.
So that makes sense, and I think that the safety profile has been pretty well characterized for this trial. Maybe, Amanda, you could speak just a little bit to what some of the risk factors were that we saw in this trial, and maybe more generally, what are some of the things that you worry about in terms of infection risk as you're counseling RA patients about some of the side effect profiles of JAK inhibitors?
Yeah, I think that the biggest one, right, is going to be older patients. So patients that were above the age of 65 had an increased risk for all infections. And so I think that's something we need to, really understand when we're thinking about who's appropriate for a JAK inhibitor. If they were higher age, if they had a baseline opioid use, a history of chronic lung disease, were they on steroids? All of these things we have to consider, as well as smoking history. I think that's going to be the biggest and one of the biggest risk factors for our patients when we look at all of these events, and also including MACE events, VTEs, etc.
Thanks, and I agree with you. Those are some of the same things I worry about as well. I guess getting down into the weeds a little bit more, thinking about how to apply this to patient care, let's talk a little bit about some of the post hoc analyses that have been done using the oral surveillance trial data to think about which patients are most at risk for some of these events and maybe which we don't have to worry about quite as much. It seems like from what we've learned even in the last couple years, that there's a few key patient traits that can help identify those that are at a higher or maybe not an increased risk for MACE or venous thromboembolism. Maybe you could walk us through a little bit of that data and some of those risk factors, Amanda.
Yeah. And, again, I think if a patient has had a previous history of atherosclerotic cardiovascular disease, those are going to be the patients that are at the highest risk. when we're, thinking about who's appropriate for a JAK inhibitor. So those are the patients that are at the higher risk. In addition, thinking about older patients and smoking, I think are really going to be the biggest factors that I consider when I'm thinking about using a JAK inhibitor for a patient.
And is your sense that this is true for all the event types or just some of them? Or give us a sense about some of these subgroups and whether we need to, worry or not worry about all of them, or how broadly applicable was this across the various safety endpoints from oral surveillance?
Yeah, if a patient is younger, if they don't have a history of cardiovascular disease, it really seems like we don't have to worry about these patients. Would you agree?
I would in general, or at least I don't worry any more about them than I would say anybody else on a biologic, or just due to the fact that they have, active RA and inflammatory disease. So I do think that it's the younger folks that are younger than age 65 that I sort of put in the average risk bucket, that some of the results of the oral surveillance trial based on the subgroup analysis, I don't have to worry about as much. Switching back to you, John, you recently published some very interesting findings regarding statin use and some additional post hoc subgroup analyses based on outcomes regarding whether people were using statins. Can you tell us a little bit about what you found?
Yeah, we were very interested in looking at whether there was a protective role of statins in the patients who were enrolled in the trial. Obviously, the patients were not randomized to be on a statin, so they were either on a statin when they started or they started a statin during the trial. One thing that we were really surprised about was that despite the fact that this being a cardiovascular risk enhanced group, that actually statin use was much less frequent than we expected, even in the patients who had a prior cardiovascular event, or in patients who had high risk based on having diabetes or other cardiovascular risk factors. And in fact, the minority of those patients were treated with statins at all, and most were not treated with high intensity statins as they probably should have been. So it's a little bit of an indictment on the care model of taking care of people with cardiovascular risk factors, including rheumatoid arthritis. We did see that patients who were on tofacitinib, both doses, did have more statin initiation during the study, and that was likely related to the drug-induced increases in LDL and total cholesterol. So that was relatively appropriate. What we were most interested in seeing was whether the being on a statin seemed to have an improvement in the differential effect between the TNF inhibitors and tofacitinib groups on events. And that is indeed what we saw. So in this graph, you can see the patients who had a history of atherosclerotic cardiovascular disease, which was the highest risk group for a differential effect between TNF inhibitors and tofacitinib. And what we found was that the patients who were on a statin, which you can see in that middle set of graphs there, they actually had the same events as the patients on TNF inhibitors. That was not true for the patients who were not on statins. They had a higher event rate, suggesting, not proving, because again, the statins were not randomized here, but suggesting that the use of statins in patients who are on Janus kinase inhibitors are potentially protected from major adverse cardiovascular events.
That seems like a really important finding. And I guess to one of your earlier comments, do you consider this to probably be a quality of care gap? And is this something that rheumatologists need to be responsible for? Why aren't these people on statins if this is a cardiovascular enriched trial?
I mean, I think there are a number of issues. There's patient preferences. There are care gaps, as you mentioned. Not a lack of referral to cardiologists, and a lack of really evidence-based guidelines for rheumatologists to empower them to take responsibility for prescribing statins for these patients. I think, in general, it is a encouragement to rheumatologists to be more proactive about encouraging statins, but it is also very, very strong evidence for us as rheumatologists to think about, I'm prescribing a Janus kinase inhibitor for this patient. They have cardiovascular risk factors. They have known cardiovascular disease. I should be responsible for both the Janus kinase inhibitor and the statin.
Yeah, that's such an important perspective. And, who is the responsible provider? Does the rheumatologist have to be the one prescribing the statin, or does he or she just need to think through, someone needs to be responsible, and that needs to be clearly delineated, even if that's not the rheumatology provider? Well, let's transition a little.
Statins are easy to prescribe. We prescribe Cytoxan for patients. I think we can prescribe a statin for patients.
Yes.
It's super interesting to talk about that, because I have never even considered prescribing a statin for a patient. Like, I just have always figured like that is outside my realm. So I've kind of started sending these patients to cardiology. We have some cardiologists in my town that do a lot of prevention, and so and they don't mind seeing my patients. So even if I think they're a bit at a higher risk, then I'll send them to cardiology. But I never really considered starting them on a statin myself. Although, truth be told, I'm ordering these lipid panels after I start a JAK inhibitor, and then when they're elevated, I'm like, you better go see somebody about that. So maybe I should be doing it.
So, Amanda, you raise a really important point. And to what extent do you view the rheumatology provider as responsible either for just referral or ordering lipids or prescribing, or do you feel like, people need to make their own decision as long as something gets done? Kind of in your area, what's typical, and does cardiology recognize that RA patients are at increased risk, or do sometimes you get sort of this blank look at you, or even a referral note that comes back that sort of says, well, why have you sent this person to me?
Yeah, I think it's a little bit of both, honestly. I mean, so now I'm very intentional on who I tell the patient to see, because I've chosen a couple of people that do understand that people with rheumatoid arthritis are at a higher cardiovascular risk, and they probably should be seen by a cardiologist. I think it is our responsibility. I think if we, in terms of at least ordering these tests, if we're going to prescribe these therapies, we really do need to understand what those risks potentially could be. And it's interesting how many people, I will often do a baseline lipid, because it's interesting how many people have not had that before I start the JAK inhibitor, because then if I do it and it's elevated, I'm not exactly sure what was causing, those kinds of things. And so I always make sure that I have a baseline, and then I will do it, because I feel like, again, it's our responsibility if we're prescribing the therapy that could potentially alter it.
Yeah, I agree. I feel the same way. I mean, if we're the ones prescribing these treatments, we're the ones responsible for monitoring side effects, or at least lab changes associated with them, and probably the most knowledgeable about those things. So let's shift gears a little bit. So let's talk about, how some of these cardiovascular risk factors relate to cancer risk, and thinking about risk stratification or patient profiling based on one or even multiple risk factors. So maybe, Amanda, you could talk through some of the risk factors for cancer that we're seeing in some of the post-hoc analyses and oral surveillance.
Yeah. So I'm kind of repeating the same thing, but it's age, right? So patients that were at older age. And I think it's also important for us to recognize that, people that are above the age of 65 are at a higher risk for malignancy anyway, but they did see that in the oral surveillance, as well as their smoking status. So it could be current smokers or previous smokers. Those patients were also at a higher risk for malignancy. Interestingly, also, patients that were from North America were at a higher risk for certain types of cancer. And if they had a previous or current history of chronic lung disease. So again, I think important for us to understand kind of what that chronic inflammation can do. I think the other thing that we need to think about is obesity, in terms of that as a risk factor, and just metabolic dysfunction, people that have diabetes, and if they're obese, and what that chronic inflammatory process can do to not only their disease, but also increasing their risk for malignancies as well.
So that makes a lot of sense. And as we think about single risk factors, but then combining them, what about younger people, for example, folks who are younger than 65 and never smoked? So I guess to both of you, John and Amanda, like, Do you worry about these people, or do you mostly think that things are probably fine in terms of their risk factors and we don't need to worry so much about them if they are younger and they have no history of smoking? How do you feel about using a JAK inhibitor in those kinds of patients?
Yeah, I think the data suggests that those patients are very, very low risk and that we can use these drugs very effectively without having to consider other risk factors beyond that.
I would echo that. That's kind of how I view it as well. If they're young, if they've had no previous history, and particularly the smoking, which, I think that's a big thing that we need to make sure we hone in on our patients right from the get go. Is if they are a smoker, they need to quit, because, as we all know, their rheumatoid arthritis is going to be more refractory if they continue to smoke. And so that's the big thing. But with no history of smoking, no previous cardiovascular events, I am not concerned with those patients in terms of putting them on a JAK inhibitor, and that's what the data suggests as well.
Yeah, I think that's why those subgroup analyses have been so helpful. An added dimension that I personally put a fair amount of weight on is some of the cancer related outcomes where it really didn't seem like the excess risk for cancer was apparent compared to TNF inhibitors until we got beyond 18 months or more, meaning that that extra cancer risk doesn't really surface until you're a year and a half into treatment. And the reason I find that so helpful as a clinician is, by the time that you've been on a JAK inhibitor for 18 months, you know if it's working and if it's working well. And if you were able to get the patient to remission or close to it, I think I don't have to worry quite as much about cancer because, again, that excess risk isn't seen early. It takes a year and a half or more to get there. So let's think now about taking some of what we've learned from these post hoc analyses and applying it to a case. So let's talk about a 52-year-old woman with CCP positive, rheumatoid factor positive RA. She started initially in high disease activity with a baseline CDAI of 51. She starts methotrexate. She's able to get to 15 milligrams a week. You try to push it a little bit higher, but she has nausea and GI upset. But at that dose, 15 milligrams, her CDAI gets better. And she was subsequently treated with biosimilar adalimumab. After 4 months, her CDAI further improves to 18, but then it plateaus. And so now she comes back and sees you. She's been on adalimumab for 9 months. Her comorbidities are hypertension. She's on treatment for that, hyperlipidemia, on simvastatin, and hypothyroidism. So that's what we're working with. So a couple of key questions I'm going to ask both of you, Amanda and John. She's had a lot of improvement in her CDAI. Her CDAI went from 51 to 24. Now 24, though, is still high disease activity. For you, is this good enough? And that's probably around an ACR 50 response. Is it worth changing therapy that for somebody who's gotten that much better, but still is probably not doing great? John and Amanda, what do you guys think?
Well, I think if you look at the ACR treatment guidelines for rheumatoid arthritis, you would say this is not good enough. Your treat to target goal is low disease activity or remission. She's clearly not in remission. The recommendation would be that for someone at this stage, that you would change her to a treatment that has a different mechanism of action from the ones that she's been on before. She's unlikely to get better with switching to a different TNF inhibitor, although she possibly could. But based on the recommendations, you should switch her to an agent with a different mechanism of action.
Yeah, I would agree. I think, this is good, but not good enough, particularly because we do have so many options for our patients at this point, and we all should really be treating to that target of getting them into remission.
And what do you both think about this comorbidity profile? So she's in that less than 65-year-old non-smoking group that Amanda, you called out as saying, maybe we don't need to have to worry about those folks quite as much. But, hypertension, hyperlipidemia, is that enough to have gotten her an oral surveillance? And is this the kind of patient that you would worry about or not so much?
I would worry a little bit. I don't know that it would, automatically. I think I still would consider a JAK inhibitor in this patient, but I would have a little bit heightened sense given that she has hypertension and hyperlipidemia, but she's treated. So, at this point, with proper treatment, I'd feel okay about it. John, I'm interested to hear what you would do.
Well, so she's on simvastatin, which is not really an aggressive statin regimen. Maybe she could be accelerated The other is you could, if you were really concerned about her, especially she's not a smoker, but if she had smoking in her history, you could consider a secondary screen for cardiovascular disease, like a coronary artery calcium score that might give you a little more information about what her cardiovascular burden was. But again, I think I agree with you that this is a patient in which a JAK inhibitor is not off the table for sure.
Yeah, I would feel the same way. I would, I think this is where the discussion comes into play with this kind of patient, but I agree. I definitely would keep that on the table as a treatment option. I'm interested to hear both of your perspectives on, what kind of a conversation do you have with this kind of a patient? How do you engage in shared decision making? How do you communicate risks that are low-ish in the 1 to 2 per 100 patient year range, but again, Amanda, you said, and I agree with you, we're going to worry some. Like, how would you message this? And if she was on a little bit of prednisone that you could get her off, like, how would you juxtapose that compared to, say, some low dose 5-10 milligrams of prednisone a day risks?
Yeah, I mean, I think, it's having that discussion, whenever I start any therapy, but specifically since we're talking about JAK inhibitors, it's discussing that, hey, there may be a higher risk, especially as you get older. And so it's really important to mitigate those things. And obviously we know that patients that are on steroids are at a much higher risk of everything. And so really making sure that we can not have this person on, have her on chronic steroid use, I think is key. I think this would be actually a good opportunity to, say, well, maybe I can get you in with a, preventative cardiologist to take a look as well. That way I already have that kind of in my back pocket and kind of see what their thoughts are as well. But also mitigating some of these other risks, like is she overweight? Is she exercising? How is her diet? All of those things I think are important as she gets older, because at this point in doing this for as long as I have, I think about the patient, okay, where are you today? You're 52 or early 50s. But, if we start this therapy, where are you going to be in 10 years, 20 years, et cetera? And so I think trying to mitigate those things right now will just help her down the road when we think about, what is her risk going to be, in 10, 15 years.
Yeah, and I think the other issue is that we need to convey to the patients that the risk of having moderate to high disease activity is also a risk factor for cardiovascular events and malignancy and all of these things. And that it doesn't benefit the patient to maintain themselves in a higher level of disease activity because that's also a risk.
Yeah, no, I think that's a great point. And sometimes people forget about, the undertreated or uncontrolled or poorly controlled RA. That's a risk factor for most all the things we've been talking about, MACE events, cardiovascular disease, et cetera. So, the offsetting benefits of, yes, medicines have some risks, but so is undertreated or poorly controlled rheumatoid arthritis. Like, those have risks too. And when I talk to patients, I try to, give them a scale analogy that there's a risk of the medications, but then there's a risk of the things that we are trying to prevent, like, badly controlled RA or some of the things that are modifiable, like smoking or, poorly controlled diabetes, et cetera. So let me throw a couple of scenarios at you, because both of you said, and I agree that, JAKs are probably on the table. Are there things that would modify that statement? So what if she was a well-controlled diabetic? What if she was a former smoker? What if she had a history, 5 years ago of a MACE event or a blood clot? How would that change your thinking about the appropriateness of a JAK? And maybe as a second question, do you lump all the JAKs in the same bucket, or without head-to-head trials, it's a little bit more qualitative, might there be some that you're a little bit more comfortable with than the others?
Well, I think that in terms of lumping in the same bucket, I think the black box warning applies to all of them. We don't have quantitative data about anything other than tofacitinib, so we have to assume they all fit in the same bucket. There is some baricitinib data that is likely to be coming out soon, but for right now, I think we have to assume that they are all the same in terms of their risk. In terms of a prior MACE event or a VTE event, so MACE event, I think we can optimize risk in those patients. A prior VT event, I do worry a little bit about in those patients, and do have a little bit of pause in a patient, especially if they've had a PE in the past, of course, that has no other explanation than that.
Amanda,
I
what are your
think that
thoughts? Diabetic, smoker, what do you think? JAK on the table, or would you probably choose that as a last resort?
for me personally, I probably would choose something different if she were older, diabetic, smoker. I'd probably choose a different mechanism of action.
Yeah, I think that would, like you, I think that would not be what I would reach for first, but sometimes your back's against the wall. Let's flip the scenario. Let's say this patient came to you and she was doing great on a JAK inhibitor and she'd been on it a couple years and she's in remission or she's at least in low disease activity. And then she has one of these events, zoster or cancer or, a deep vein thrombosis. Do you stop the JAK? And if so, then what do you go to? And I don't think there's a whole lot of data about that, but how would you approach somebody with a new event already on a JAK inhibitor where it's really working well?
I mean,
So
that's a
I've
tough
seen,
situation.
oh,
Let's stop. All right, hard stop. Go ahead.
so I've had patients that have experienced this, and thus far, I have stopped the therapy and chose something different.
Yeah, and I think that it depends on, again, shared decision making. What the patient wants to do. They feel very comfortable with the drug. Obviously, if they're anticoagulated, then you might feel very comfortable continuing. Now, that may not last forever, but again, it helps to have maybe the hematologist involved and you involved, and making decisions with everybody well informed.
Yeah, I think that makes sense. And I guess for me, I might add the small point that if there's something I can do about it, that you mentioned, can I optimize a risk factor? You weren't anticoagulated and now you are. John, that was your example. Or, if this was a MACE event, your blood pressure was poorly controlled, you weren't on a statin, and there's things that I or, the provider team taking care of the patient can fix. I might view that a little bit differently than if you are medically optimized in all ways and you have an event. That's going to worry me more because there's nothing I can do to mitigate that risk. And my only treatment option is perhaps to switch the therapy. If that's the only thing I can change to mitigate risk, I think I'm more likely to do that. Whereas if I could start a statin, I at least would be more open to the idea to continue the JAK just because it's working so well.
Right.
So maybe one key topic to speak to, because we've got some new data about people that have been on a JAK that are cycling to a new JAK. And John, you touched a few moments ago about people that are on a TNF that might cycle to the next one, and that seems somewhat out of vogue based on some evidence and certainly international guidelines. But there's now been a couple studies published, the Jackpot trial out of Europe, and then the first Japanese registry. Can either or both of you speak to what we know about cycling from one JAK to a second JAK?
Oh, I'll go. Yeah, I think that we've learned with the TNF inhibitors that in patients who have had good responses but have lost their response, that we can switch to a different TNF inhibitor. They can often do well, and that seems to be the case with JAK inhibitors as well. And that cycling between Janus kinase inhibitors can result in better outcomes.
Yeah, that's what I've seen too. And I think we are all doing this, right? Like we all, pending on what other options, what has the patient tried? Are they more refractory, et cetera? I certainly have tried switching from one JAK to another and had success in doing so.
I have as well, and I think that some of it might be the dose in addition to changing the drug, but maybe cycling from one JAK to a second, now that we have some evidence, is not as unfavorable as doing that in the TNF family, where there is reasonable evidence to say that maybe is not the best option. So as we're getting close to time, let's maybe think about one or two last topics. The first is if either or both of you could summarize, how do we mitigate some of the risks for infections and other adverse events? We've touched on a few of those, but as you're thinking through, what is the array of things that we could do or we could recommend? And a related topic, how do we best partner with other clinicians in primary care, cardiology, and other specialties to make sure that patients are getting all the preventive treatments that we can and should be offer them, and maybe do better than what oral surveillance showed us, where only about a third of people ever got a statin, even though all those patients were at high CV risk? How do we optimize that?
I think the key first and foremost is making sure our patients are up to date with their vaccinations. And, oftentimes if they're younger, that can be a little challenging because they go to their local pharmacy and they're told, well, you're not 50, and so you really can't. And so I think it's making sure our patients know that, no, yes, you should. And so oftentimes I'm giving them an order to take with them so that they can get their herpes zoster vaccine, so they can get a pneumonia vaccine. I think that's absolutely crucial, and I think could help mitigate some of the risk. I think we all know that steroids are, the devil's candy. Somebody referred to it as that the other day. Now I've been using that in clinic. And it's true, right? Like, obviously they work wonderful, like they're game changers for our patients, but we really need to try to get our patients down on that glucocorticoid dose, or off, to help mitigate their risk, as well as, again, diet, exercise, weight loss, I think are all really important. When we're talking to patients about, what can we do right now so that in 10, 15 years, you don't have a problem.
I think that people often forget that there is a recommendation for low dose CT scanning every single year for a person who has either a current smoker with a 15-pack year history or a former smoker with a 15-pack year history, to get that done every single year for lung cancer screening. And that applies to RA patients regardless of their treatment, and especially JAK inhibitor treated patients.
Yeah, I think that's a great point. And you mentioned some of the additional risk stratification, like coronary calcium scores, that in some patients might be useful, just to get a little bit more information to help make an appropriate decision. Well, we're getting close to time, and just to summarize a few of the key takeaways, we've learned a lot over the years now, having had JAK inhibitors for more than a dozen years. We've got a lot of data on the safety profile, but some of the new post-hoc analyses published in the last couple of years for the concerns about major adverse cardiac events, cancer, and VTE, those rates are low, generally in the 1 to 2 per 100 person year range, even in those enriched for cardiovascular risk factors in oral surveillance. But judicious patient selection is key. And some of those analyses have showed us that, for never smokers and people younger than 65, the risk profile of tofacitinib and probably other JAKs is pretty comparable to TNF inhibitors. It's the older people, the ones with prior events, smokers, that probably is where most of the excess risk is confined. But shared decision-making with patients is really critical to best select which therapy might be most suitable for individual patients. Amanda and John, thank you so much for this great discussion. Really appreciate your time, and thank you as a learner and participant for being part of this activity. Please remember to continue on to answer the questions that follow and then complete the evaluation.